So here's a quick video on a very simplified risk score for post-op nausea and vomiting, so that if your attending staff asks you why he or she is giving a particular anti-nauseant at a particular time, you'll have a bit of a basic understanding. So, risk scoring will be based on four very simple properties that are essentially yes or no. And these are based on kind of major risk factors that have been identified for post-op nausea vomiting, which affects between 20 and 30% of all surgical patients. So it's one of the most common post-operative complaints of surgical patients. So our very basic risk score is based first off the patient's gender. If they're female, they get 1 point. If they have a past history of PONV, that's also worth a point. If they are a non-smoker, that is worth a point. And as well, if they are being given perioperative opioids. As any of us who have taken opioids know, they can be very powerful nausea inducers, so that's also worth a point. So we add this up for a total of between 0 and 4. Now, if they have 0 to 1 for total score, don't even need to worry about prophylaxis. So you don't give them anything during the procedure. If they have 2, you can use monotherapy. And if they have 3 or 4, you can use multi-therapy, or even consider TIVA instead of a general anesthetic, because the volatile gas, whether it be desflurane or sevoflurane or even isoflurane, can be very powerful nausea inducers as well. So when we talk monotherapy or multiple therapy, the most common agents and most common doses, probably the most common agent is serotonin receptor antagonists called ondansetron. And that's usually given in a 4 milligrams IV dose, about half hour prior to end of surgery. That's one option. Another option is corticosteroids, dexamethasone, and that's usually given 4 to 6 milligrams IV at induction. That's another option. And then a third choice there's dopamine antagonists that work in the chemoreceptor trigger zone. The most common one used for this purpose is droperidol. Now we could do a whole other video on the tragic story of droperidol, but we don't have time for that right now. For all intents and purposes, it does have a black box warning for prolonging the QT interval. However, the evidence behind that is not fantastic, but we don't need to get into that now. And it's typically given in a dose of 0.625 to 1.25 milligrams IV, and as well is given like ondansetron towards the end of the case. So to summarize, we have a very simple risk score based on the patient's gender, whether they have a past history of post-op nausea vomiting, whether if they're a non-smoker, and if they're being given perioperative opioids. Based on that risk score, you can decide to give them either no prophylaxis, monotherapy, or multiple therapy. You can even adjust your type of anesthesia. And if you are deciding to give anti-nauseants, there are a number of options. 3 of the most common are ondansetron, dexamethasone, and droperidol. Thanks for watching.